Orbitozygomatic approach. The patient is positioned supine with the head fixed on a 3-pin Mayfield head holder, facing contralaterally with the neck slightly hyperextended. Local anesthesia is injected subcutaneously, and the scalp is incised on a semi-linear manner, starting anteriorly to the ipsilateral tragus towards the contralateral mid-pupillary line slightly behind the hairline. The skin flap is elevated until the temporalis fascia and subgaleal fat pad are identified. The fascia is then incised, dissected along with the fat pad, and elevated until the frontozygomatic process, zygomatic arch, and supraorbital notch are exposed. The temporalis muscle is dissected from the temporal fossa and everted antero-inferiorly. The muscle fibers attached to the frontozygomatic process are dissected until the inferior orbital fissure is identified extraorbitally. Once our dissection is complete, we plan for a standard frontotemporal craniotomy. A McCarthy keyhole is done at the frontosphenoidal suture, 2 centimeters posterior to the frontozygomatic process. A second burr hole is placed at the lateral aspect of the temporal bone. Using a footplate, we begin our craniotomy from the temporal burr hole superiorly around the temporal fossa until the frontal bone, using the supraorbital notch as a limit to curve back towards the McCarthy keyhole. A second inferior osteotomy is performed to release the frontotemporal craniotomy. Once the frontotemporal craniotomy is complete, we plan for a series of 5 osteotomies along the zygoma as illustrated here. Osteotomy number 1 is performed at the zygomatic arch. Osteotomy number 2 is performed in the shape of an arrowhead using the bone saw at an oblique angle to free the body of the zygoma. This osteotomy is done from the inferior orbital fissure and towards the body of the zygoma. A footplate can also be used to do this osteotomy by placing it intraorbitally in the inferior orbital fissure and cutting towards the body of the zygoma. Osteotomy number 3 is performed from the orbital ridge just lateral to the supraorbital notch along the roof of the orbit towards the superior orbital fissure. Osteotomies number 4 and 5 are then performed to release the lateral wall of the orbit. The cuts are done extraorbitally from the inferior orbital fissure towards osteotomy number 3. The zygoma bone is then elevated and placed aside. The exposure of the approach is now complete. In some cases, we prefer to place the titanium plates and screws before removing the bone piece for a smooth reconstruction after the procedure, as the bony anatomy is distorted during the osteotomies. To begin the reconstruction, we prepared the orbitozygomatic and frontotemporal bone pieces with titanium gear at the points where osteotomies were performed. The orbitozygomatic piece was secured in place and was followed by the frontotemporal piece. The temporalis muscle is inverted and reattached to the myofascial cuff base at the superior temporal line. The temporalis fascia incision along with the temporal fat pad are then closed. To finalize the procedure, the subcutaneous tissue and scalp were approximated and sutured. Thank you.